Hello, dental surgeons. As I talked in part 1, after knowing history, blood investigations, getting physician's opinion, and informing the patient with written consent for possible excessive bleeding, you and the patient both are ready for the surgery under LA, I think. Now, the pre-operative preparation starts with prescription of suitable antibiotics and anti-inflammatory drugs, chlorhexidine mouthwash to reduce local infection and inflammation. Remember, this infection and inflammation will cause hyperemia, aiding to bleeding that is going to happen due to systemic causes. Now next, plan the appointment time in such a way that you can observe the patient for minimum 1 hour in post-surgical phase. After this, prepare needed materials, instruments and equipments to control bleeding that I have discussed later in this video. And don't forget to measure immediate pre-surgery blood pressure and document it. Now you need to be ready with local hemostatic agents like botroclot solution, absorbable cellulose like Abgel, which acts as mechanical scaffold for clot stabilization, or Surgicel, that is oxidized regenerated cellulose having low pH, which will degrade blood cells, precipitate proteins and will plug the bleeders. You can have Act Cell, which is a cellulose fabric meshwork, and it increases platelet aggregation biochemically and initiate clot stabilization physically. One more product is Blood Stop. It is a regenerated cotton cellulose which helps in blood coagulation. The last two products have benefit of normal or neutral pH that will cause least damage to local tissues and least inflammation. I have mentioned company names, but you can choose whatever product you like. The other material is atraumatic sutures. The better are the threads on swatched round body needles and gauze packs. The third is, if possible, you can manage dental cautery or laser unit, which helps to control bleeding by burning the local tissue cells and precipitating proteins which plug the bleeders. Now comes the execution of surgery in such a way that we encounter minimum bleeding. For this, your surgery will have to be least traumatic. You are supposed to keep in mind that don't puncture tissue multiple times with LA needle to avoid bleeding in deep tissue planes. Take care not to lacerate soft tissue while reflection. Use proper sized sharp periosteal elevators to detach gingiva and keep it reflected. Don't puncture gingiva or vestibule mucosa with forceps bex. Try not to break or cut bone plates. If it fractures accidentally, suture to stabilize them. Don't leave sharp bone edges, smoothen with bone files. Take good support to avoid instruments slipping and injuries to the soft tissues. Now, after completion of the surgery, check for immediate bleeding. Use electrocautery or laser if required. Pack the socket with chosen cellulose pack and suture the gingival papillae to keep it staying there. Don't try to make it watertight closure because the bleeding will get seepage into deeper tissue plane leading to ecchymosis or even hematoma. You can place botroclot solution soaked gauze pack over the region and ask the patient to bite on it tight for 1 hour. Advise extraoral ice pack also. Make the patient sit in the clinic and re-evaluate after 1 hour. That is initial clot stabilization time. Now after 1 hour, if there is no excessive bleeding, relieve the patient after explaining post-surgery home care and recall after 24 hours as well as after 3 to 5 days. You can prescribe oral hemostatic medicines like tablet vitamin K 5 to 10 milligram per day or tablet ethamsilate 500 milligram 3 to 4 times a day. Ethamsilate stabilizes blood vessel walls and improve platelet adhesiveness. If it is bleeding more after 1 hour or later on follow-ups, even after all care taken, re-evaluate surgical wound, give local hemostatics and refer the patient to the physician as he requires parenteral medications like injection of tranexamic acid, botroclot, vitamin K or even platelet transfusion or clotting factor replacements. Stay in talk with the physician, re-evaluate the patient and the surgery wound after 3 to 4 days and check bleeding control. In such patients, minor oral surgeries under ALA usually do not lead to profuse, continuous, immediate bleeding if we follow discussed principles. But some patients do return after 2-3 days or even after a week with passive, continuous oozing of blood, leading to formation of a large, partially organized purple red blood clot collected in the vestibules. For such patients, you need to remove that clot and debride the region. Repeat the same local hemostatic treatments with electrocauterization if required, cellulose packing, oral hemostatics, and again refer the patient to the physician. If we follow basic principles to avoid bleeding complications, take good care of the patient's physical condition and good help of the patient's physician can make the patient understand his condition with its complication and his role for following instructions, definitely we can safely treat them for minor oral surgeries under local anesthesia. Whenever there is no any conservative management is possible. With all this, never forget to document everything. Friends, I hope this will help you and the patients for better treatments. Thank you everyone.